A 29-year-old promiscuous male got a painless, indurated button-like ulcer over the glans, which healed only to recur at the same site. This ulcer is called Hunterian chancre, chancre redux, pseudo-chancre redux, or chancre d'Embly. Hello everyone, welcome to my class. This is the second class on syphilis, and we are going to learn about the primary syphilis, its clinical features, variants, diagnosis, and treatment. So let's start. Primary syphilis is represented clinically by chancre. Chancre is a painless ulcer, the details of which we are going to study. Where is the chancre seen? It is seen in the genitalia. In males, the sites of predilection are coronal sulcus, frenulum, glans, prepuce, penile shaft. While in females, they are seen mainly in the fourchette, labia minora, vestibule, clitoris. These are the main sites. Now, extragenital chancre are seen in about 5% of cases. They are found over lips, tongue, tonsils, finger, and even breasts. Anal or the perianal area is another site in genitalia where chancre can be seen in both males and females. The classical chancre is called hard chancre because on consistency it is indurated. True chancre because there is another disease known as chancroid which has been discussed in previous classes, and Hunterian chancre. John Hunter, this is John Hunter who did a very controversial experiment. His hypothesis was that gonorrhea and chancre are two presentations of the same disease. So what he did, he took the secretions of gonorrhea and inoculated to a patient, and the patient was most probably himself, and he got a chancre. So this is also known as Hunterian chancre. Later it was proven that both are different diseases and chancre and gonorrhea have different causative organism. And the patient from which John Hunter took the secretion probably had both the diseases and both the organisms in the secretion. Now, how does a chancre look? It is usually solitary, maybe a few, 2 to 3, painless, hard or indurated, button like or cartilaginous in consistency, clean looking, exudes serous discharge, and it is punched out. Chancre and chancroid has been differentiated clinically in my chancroid class. You can go through it. Now there are various types of chancre. Mixed chancre. Here, along with Treponema pallidum, there is some other STI like H. ducrei or chlamydia or herpes, genital herpes. So the morphology may get modified a bit. Next is the phagedenic chancre. Here, the chancre gets secondarily infected with other bacteria like Fusobacterium, and the lesion is very destructive in nature. Next is chancre redux. This was one of the options of the question that we started with. In chancre redux, what happens? The chancre gets healed and then it reappears at the same site, maybe due to insufficient treatment, and it is accompanied by lymphadenopathy. There is something called pseudo-chancre redux. Here, the gamma, which is a lesion of tertiary syphilis, appears at the site of the primary syphilis chancre. So, in reality, it is not a chancre, it is a gamma. The next two types are very important. Edema indurativum or penile venereal edema. Here, along with the chancre, there is severe edema of the genitalia, the prepuce and glans in male and the labia in the female. Next type is syphilitic balanitis of Folman. Here, the patient presents with a lesion like balanitis, like similar to candidal balanitis, you can say, without a chancre, but the serology for syphilis is positive. Eugen Folman was a Hungarian dermatologist who first described this clinical variant or presentation of primary syphilis. Now come back to the diagram. There is something called condom chancre. If the patient wears a condom, the distal part of the penile shaft is covered with condom. So he will get the infection of T. pallidum or develop a chancre over the proximal part of the shaft or over the pubic region or over the groin. This, due to the site, is known as condom chancre. There is another term called lymphangitis dorsalis penis. It is also known as sclerosing lymphangitis of penis. It is a benign condition and it presents as a firm, painless, cord-like swelling along the coronal sulcus or the dorsum of the penis. Initially, it was thought to be associated with syphilis, but later it was proven that it occurs in any sexually active men and probably with people who have high activity. A very often asked question in Viva is Dory flop sign. Here what happens if the chancre is over the prepuce and you try to retract the prepuce, the indurated syphilitic chancre flips out all at once rather than the prepuce rolling back smoothly. This is due to the button-like or the induration of the chancre. This is known as Dory flop sign. Students should remember penile venereal edema and syphilitic balanitis of Folman. This balanitis can be considered the non-chancre presentation of primary syphilis. One very important clinical finding is the regional lymphadenopathy. It appears about 1 to 2 weeks after chancre. It is usually bilateral in genital lesions and unilateral in extragenital. It is discrete, firm, indurated, non-suppurative, painless, rubbery or shorty in nature. The differentials for chancre are all the ulcers of other genital ulcer diseases like chancroid, pneumocystis, herpes genitalis and even LGV. Others are traumatic, ulcer, Behçet's or even malignancy. Now we'll see some clinical pictures that I have collected of various presentations of chancre. This is over the glans. This is over the vagina. This is over the finger, extragenital sides, over the tongue. Note the punched out appearance of the ulcer. This is the syphilitic balanitis of Wolman. You can see how the chancre almost looks like a balanitis and it was positive for treponemes and after penicillin it healed very nicely. So this is a case report from IJSTD and the other images are from the CDC Public Health Image Library. Now we are going to see a video of the famous Dory flop sign of primary chancre. Dory is a small flat-bottomed boat which when pulled laterally flips suddenly. The Dory flop sign was named after the flipping action of a dory boat which resembles the motion seen when retracting an indurated prepuce in primary syphilis. The video credit goes to Dr. Shomil Khare, a faculty in Department of Dermatology in AIIMS Raipur. Hope after this video you will not forget the Dory flop sign. Now moving on to the diagnosis of syphilis, primary syphilis. In short, I'll be describing because one whole class will be dedicated to diagnosis of syphilis where we will go into the details of it. So in primary syphilis, we can actually have two things. Either we can demonstrate the treponemes via direct detection tests or we can demonstrate the antibodies via the serology. In direct detection, the first thing is the dark field microscopy. In dark field microscopy, about 80% of cases we can find the treponemes in the chancre. It is the most sensitive and specific test for primary syphilis. The treponemes can be demonstrated from the serum exudate or even from the lymph node aspirate. The second one is DF80-TP, that means direct fluorescent antibody test for Treponema pallidum. The advantage for this test is that it can be used for oral lesions where dark field may be confusing due to the indistinguishable commensal spirochetes over the oral mucosa. The third one is the ELISA for Treponema pallidum. It can be done from the serum of the chancre. One such test is known as visual test. The second group of tests is the serology, where we demonstrate the antibodies for that spirochetes, that Treponema pallidum. Here also there are two groups of tests, the non-treponemal tests and the treponemal tests. In non-treponemal test we have VDRL or the RPR test. In non-treponemal test the antibodies are non-specific against the lipoidal antigen of the treponema, so it is called non-treponemal. It is positive in 80% at presentation and it becomes positive after 2 to 4 weeks of developing chancre. If negative, we have to repeat it in 1 week, 1 month and 3 months. This test turns negative after treatment, so it should be repeated in follow-up. The next set of tests in serology are the treponemal tests. Here one example which is very commonly used is TPHA. TPHA means Treponema pallidum heme agglutination assay. And another test is FTA-ABS. That means fluorescent treponema antibody absorption test. These are positive in about 90% of cases at presentation, and if negative it doesn't rule out the infection, or if positive it doesn't establish that the patient has got a recent infection, because even if the patient had the infection from very long time, it will be positive. It will not differentiate whether it is treated or not treated, because once the patient gets positive for TPHA, he will remain lifelong positive. So once positive, always positive. So TPHA does establish that the patient had the infection, whether past or present, anytime in his life. In some rare conditions, the TPHA can get or turn negative, and these rare conditions we'll discuss in detail in the diagnosis lecture for syphilis. Now moving on to the treatment for primary syphilis. It is very easy. It is just a single dose of benzathine penicillin 2.4 million units IM, and this is the penicillin powder and this is the water for reconstitution. Though it is easy, this injection is very painful for the patient. So in adults 2.4 million units once, in children it is 5000 million units per kg once, and max it should be 2.4 million units. Now what we can do in penicillin allergy or what are the alternatives we'll discuss in detail in a dedicated treatment class for syphilis. Now coming back to the question, painless indurated button-like ulcer over glands healed only to recur at the same site. Now we know the answer is clear, chancre redux. This last term, chancre d'Embly, is the wrong term. It should be syphilis d'Embly. With this, we come to the end of today's class. I hope you have enjoyed the class and I have made some concepts clear for you. If this class has benefited you in any way, do like and subscribe. There are many other lectures in the channel. Please, you may go through it. Meet you in the next class of secondary syphilis. For now, bye.